So thank you so much to the organizers for inviting me here. It's really a privilege to be here in the Data Science Summit in Ghana. And I'm going to be talking about predictive analytics in healthcare and what are the elements for building successful pipelines. So I was going to say a bit about me, but after that introduction, I think it's not necessary. But there's one detail that has been forgotten, which is where I'm from. So I'm from an island called Trinidad and Tobago, and this is Trinidad there. So you see it's just off the coast of Venezuela. But actually, if you look on the global map, it's this tiny square there. So Trinidad has a population of 1.2 million people. It's a very diverse population, a very interesting country. And I lived there, so that's where I had my schooling. And I lived there until I was 18. And I think it was there that I had a math teacher who really inspired me to go into mathematics and statistics for healthcare, which is what brought me along this path. So I'm not going to go through my introduction. One thing that I have done was I did work in GlaxoSmithKline. So I've worked in several companies looking at machine learning and predictive analytics for health. And I think one of the highlights, I spent quite a bit of time in academia. So I spent 6 years in the University of Manchester, both as a postdoc and doing my PhD as well. And I went to GlaxoSmithKline after a year of postdoc. And there it was really interesting seeing how statistics and machine learning works in a real life setting in the pharmaceutical industry and how we can deliver products to people. So my research. Most of my research, as was mentioned in that lovely introduction, is based on latent variable modeling. And what latent variable modeling is, when you have a disease, you have different symptoms. And I don't know if you have the experience, when you go to a doctor, very often the doctor would give you a diagnosis, but sometimes we realize that people have very different responses to treatment. So with latent variable modeling, a lot of what I do is looking at symptoms or what you observe, which are the squares, and trying to find, is there some underlying structure in that development over time? So with latent variable modeling, we're trying to understand, can we see subtypes of disease? So an example would be lung cancer. So you can have two patients who have a diagnosis of lung cancer, but they respond very differently to treatment. So using latent variable modeling, can we identify, are there some clues in the data where we could identify these different structures? A lot of my research as well is focused on longitudinal data analysis. So I've done a lot of work on longitudinal cohorts where you have people you're following up over time to see whether they develop diseases, what is their genetic makeup, what are the environmental characteristics. So a lot of work is focused on how can we model longitudinal data. Also, missing data is an important problem, the absence of data. So I do a lot of work around how can we investigate mechanisms for missingness? And is that, because sometimes when you have missing data, that could bias our results in an analysis. I also look at causality, because of course in healthcare, we're very interested in finding out can people not hear me? Okay. That's much better. Okay, thanks. If I speak too quickly, just raise your hand, because sometimes I speed and I have a weird accent. So causality, because in healthcare, and then also looking at patient-centric approaches as well, because this is what the heart of healthcare is, that we're looking at how to cure people, how to cure individuals. So very often it's taking into account different strategies, different data measurements from patients. And a lot of the work I do is in teams which are multidisciplinary as well. And this is a really important part for building good data science models. And this was something that came up in the talks earlier as well. So good. I see people aren't sleeping so far, so good. So basically, this is the roadmap I want to present today for predictive analytics for healthcare. So the first part I'm going to present is what are the drivers of predictive analytics in healthcare? What motivates what we do? In the second part, I'll talk about a more historic perspective, evaluating data-driven healthcare. What are the building blocks of data-driven healthcare and where did we come from? And I think it's really important when looking at, there's so many advances in technology and advances in data science skills now and in machine learning. I think it's really important to look back at the first principles. Where did we come from? Because sometimes those first principles are the things that we really need to do to get meaningful insights from healthcare data. The third part I'm looking at, I'll go through the parts of study design and some important concepts around study design as well. And I think this is really crucial for doing good healthcare analytics. And part 4, these are my top 10 data science skills. And actually listening to some of the talks, I have left out some, but I think these are the top 10 skills for data scientists to do successful predictive analytics in healthcare. So the first part, the drivers of predictive analytics in health. So the key stakeholders in health are us, patients and persons, each one of us, the population, the pharmaceutical industry, and healthcare providers as well. And this is really important when we are looking at predictive analytics in healthcare to have in mind what are we trying to do? Where are the questions coming from? And these are the drivers for those questions. I think starting with the patient or person who is at the center of healthcare. So machine learning and data science has the capacity to transform healthcare. And with data science in healthcare, what we're trying to do is understand physiological developments in a person, understand how a person changes over time, what leads to development of disease, what leads to cures of disease as well. And it's really important, therefore, that the research we do in machine learning and data science and predictive analytics for healthcare is focused on helping people, on the patient. Also, the patient is at the center because we want to forecast progression of the onset of disease, and also we want to look at possible strategies for personalizing treatment as well. The next driver of healthcare is the population. So, okay, we could talk about personalized healthcare, but if we want to do predictions, we have to look at the person in the context of a population. And with the population, this is what we as a society do collectively to ensure conditions in which people can be healthy. So, population as a stakeholder, we want to look at average effects and deviations from those average effects as well. So you may have people who have certain conditions, and we want to see why do they deviate from the average person with those conditions. For example, why does a treatment differ for a particular person? Also, looking at population data as well can help us with policy recommendations as well. And this is something that I'm sure happens here. It happens a lot in the UK. So the problem in the UK right now is obesity. And it's a health problem because you have increased people going to the hospital for something that's preventable. So, and another problem is that of mental health as well. So we are looking at, with policy recommendations, these are government-based strategies where they're trying to look at how can we intervene on a population level to prevent people getting ill. Also, there's looking at population data for health education, and again, that's very often government-driven strategies. Outreach, research of disease detection and injury prevention. So there are lots of screening for cancers, early detection of cancer, especially in many countries, to help to intervene early on if someone develops cancer. And also, population-driven healthcare statistics can also reduce healthcare inequalities. So when you look at the population, one of the things that we want to bear in mind is how can we reduce inequalities so everybody has the same health, the same access to health, and the same health benefits from the system. So the other stakeholder is the pharmaceutical perspective. So pharmaceuticals are into developing drugs and therapeutics, and very often this is developed in healthcare on a population level. So typically the pipeline in the pharmaceutical industry is you have an idea, you have a disease you want to cure, you have an idea how to cure it. So these could be through looking at molecules, trying to target specific molecules. And then you do some basic research. So basic research is all about looking at the first principles of a disease. So can we look at the molecular development of the disease in order to target molecules? And then once you find a molecule or something you could target with an intervention, you take it to a clinical trial and you test it out. So you have different phases of a clinical trial. The first, and I can't remember these very well, but the first phase of a clinical trial is where you're doing studies on healthy patients, and not healthy, on a healthy population. They're not patients, they're healthy. And this is basically to see whether there are any side effects that come out of that. In phase 2, you're testing it, you do a pilot study on a smaller population, and in phase 3, you do a larger study. And all of these, you have to get the sample right. So what is the sufficient number of people? We have statisticians in the room, that's great, in order to see some sort of good effect. And then you have some regulatory approval if a drug is successful, and this is deployed to the patient. And also, the fourth stakeholder are the providers and regulators of healthcare. So there are many different providers. In the UK, we have a regulator called the Medical and Health Products Regulatory Agency. So they look at things like, if a drug's on the market, are there people getting adverse conditions? Also, the Food and Drug Administration, so they look at approving drugs once they're in phase 3. In Africa, there's the African Medicines Agency as well, which regulates medication on the continent. And then European-wide, there's the European Medicines Agency. So if a drug wants to be approved in one of these places, usually it has to go through the required agency. All right, so the second part, looking at evaluation of data-driven healthcare. So as I mentioned, I'm going to give a more historic overview of data-driven healthcare. So the current state of healthcare data is we have a lot of data. It was quite striking seeing the previous few talks where they were talking about the volume of data that is available through transactions that people make in insurance. And it's the same with health. So people have things like mobile phones, which some companies use to collect data, or you have things like smart watches as well. And these are quick and cheap ways to collect data from individuals. And there's all sorts of health data. You have patient records from a hospital when someone visits a hospital or visits the doctor. There's data that's generated. So there's a tsunami of data. There's a vast amount of data, and that data is coming in with a great velocity, in great volume, and in great variety as well. So how do we sort of tackle this tsunami of data? And then there's a blizzard of methods. So there are these machine learning conferences every year. They get 7,000 publications, 7,000 submissions to these machine learning conferences like NeurEPS and ICML. And each paper has a new technique, a new way of solving a problem. But despite the amount of data and the amount of methods there are available, there's a drought of human expertise to look at this growing amount of data and make sense of it. And this is a global problem. What do we do with the data? Finding people to look at data. So big data are not a solution. This is a myth. We need to be able to take big data and get some sort of meaningful insights. Another myth is we have the models needed to turn healthcare data into decision support algorithms. We don't. We're still scratching the surface, because once you do an analysis, how do you actually implement that in a policy? I think it's more straightforward to see in the pharmaceutical industry, but in other settings where it's not, maybe the process isn't regulated, it's a lot harder to do. And another myth is clinicians would be the main source of data. So the main sources of data are things that we generate, people generate. So machine learning, there's been a lot of talk about, and we're at Indaba X, which is the deep learning Indaba, so we're offshoots of that. And machine learning and deep learning has the potential to have a huge impact on healthcare. But I think it's also important to really remember the beginnings of data science in healthcare. And the start of data science in healthcare is in epidemiology. Just simple things where you have a population, you look at a population, see how many people are diseased, how many people are not diseased. And these are the building blocks, the first thing we need to do for good predictive analytics. So every good data scientist working in healthcare should be a good epidemiologist as well, because these are important building blocks. Can I just ask, how many people work in healthcare here? Okay, all right. So just 3 people. All right. Okay, wow. All right. So this isn't known. Good. All right. So except for you 3 probably. So the study of epidemiology's study of the distribution and determinants of health-related states or events in specific populations and the applications of this study to the control of health problems. So this is what we want to do. And epidemiology started in, well, we see the first statistician was a woman. There's a lot of talk about women. Florence Nightingale, who was born in 1820 and died in 1910. And Florence Nightingale was a nurse during the Crimean War. And she noticed that a lot of soldiers were dying, even though they were cured of the injuries. And she wanted to know, what is it that people are dying of? So she did these plots, which is a visualization tool of data, to try to understand, to get insights into the data. And Florence Nightingale is known as the first statistician or first data scientist. So she looked at army data, and she found that 16,000 out of 18,000 deaths were not due to battle wounds, but due to preventable diseases spread by poor sanitation. So due to this, Florence Nightingale was able to develop strategies to help to improve sanitation. And also, I think this is an important lesson in that we have to anchor good data science for health in the power of observation. So this was a second study just after Florence Nightingale by someone called Jon Snow. So Jon Snow in London. What's so funny? Is there someone called Jon Snow here? Huh? Ah, right, not that Jon Snow, no, okay. So yeah, another Jon Snow. So great, so you're awake. So Jon Snow was as well as someone in the Game of Thrones, he was an epidemiologist, not the same Jon Snow, it was a different Jon Snow. So he noticed that in London there was an outbreak of cholera, and he wanted to know what was the cause of cholera. And there was a theory that it was a virus, but then he noticed that people who drank from a pump in this particular street in Soho in London were developing symptoms of cholera. So he looked at, this was a story of how you can look at contextual phenomena, for example, the cholera incidents, and look at how can you compare cholera rates in people who are exposed, for example, to this pump, and who are not exposed to this. And the third statistician I'd highlight is someone called R.A. Fisher, who looks at the principles of experimental design. And this is another way that data science is led by the power of observation. So R.A. Fisher was working in plants, actually. There's no one called R.A. Fisher on Game of Thrones, is there? So he looked at why do 2 plants differ in growth. So he noticed, he was working in a place called Rothamsted, and they were looking at plants. And he noticed that there were some plants that were growing well and some plants that weren't growing well. So he wanted to see whether this was due to where the plants were planted. So he developed the technique of randomization, which is unbiased allocation of treatments to different experimental plots. So you have different plots, and you just randomly put plants in 2 plots, and then you replicate in different areas, and you try to see whether there's a difference between them. So randomization is a way of reducing error, of controlling error and reducing error variance. So I'm going to dwell quite a lot on important concepts in study design. So this may be a bit of a harder part, actually, because I'll just be defining some, looking at definitions of different study designs, but I think it's really worth thinking of, especially if we're thinking of solving problems in healthcare analytics as well. And then the fourth part, I'll do my top 10. So good study design is really important. So you need to set up a study to answer a particular research question. And design is actually the most important aspect of data science or predictive analytics or whatever you want to call it, machine learning. It's the most important part, but also it's the most neglected part as well. So study design, how you design a study needs to match the research question. So if the study isn't adequately designed, then we can't answer the question we want to answer. And I think this is really important as well, where we have that tsunami of data. So very often with the tsunami of data, we just have data, and maybe what we're trying to do is a posteriori, after the fact of getting that data, we're trying to do some sort of analysis. But really, it's worth stepping back and seeing, well, is the data and is the study adequate for addressing the question that I want to ask as well? Otherwise, we're wasting time. So it's important that the study design should match research question, so we don't end up collecting useless data or the principal outcome ends up not being recorded. So it's always good practice that statisticians or data scientists are there at the beginning of the data collection process. So before people even think of collecting data, it's really important that we get involved in studies and also that we advocate to be involved in the development of questions as early as possible. And this is for this reason, so that we could also influence how the study is designed, how many people we get on a study, and these sorts of things. So no matter how good an algorithm is, if the study design is inadequate, garbage in, for answering the research question, we'll get garbage out. So in computer science, there's this famous expression, garbage in, garbage out, and the same with data science as well. Not just for health. I think, well, health is what I've worked in for a long time. I think with many things as well. If you have garbage in, if you have bad data, bad study design, you get garbage out as well. And also you find it really hard to replicate in other populations if the studies aren't set up well. So I've motivated why I'm going on with study design. So good predictive analytics for healthcare starts with good study design. And three main questions we should ask ourselves is, what is the question or hypothesis I'm trying to investigate? Is the data I have, if the data has already been collected, is it adequate in order to address that question? And how can I design a study to address those questions? So what would be the optimal way of designing a study? Because sometimes we don't live in a perfect world, and very often we're not involved in the stage of designing the study. But it's good to think, how would I have designed this study if I could have been there at the beginning? So I'm just going to run through, well, not run through, I'm going to dwell quite a bit on different types of studies. So this chart, I don't know, can you see that okay? Yeah, okay. So there are different types of studies. So we can break them down into non-experimental studies or observational studies. So this is where we're just observing something, we're observing a phenomena. And then the other type of study is experimental or intervention studies. So that's what I touched on when I was talking about looking at predictive analytics in the pharmaceutical industry, where you're randomizing patients to different groups. So within experimental studies, you have randomized clinical trials, and randomized clinical trials are the gold standard for any study design. So I'm not going to go through that in detail, but basically with randomized control trials, what you do is you have a population that is a control, a population you give an intervention, and you try to see what is the difference between those two. And you can also have community trials or non-randomized trials as well, where you have some people who've taken an intervention and some people who've been given a control, but it's not assigned previously. So in non-experimental, there are descriptive studies and analytical studies, and these all have their value. And I think it's really good, even though some of these methods are quite simple, they're very powerful as well for giving insights for bigger studies. So in descriptive studies, we have case reports, case series, and cross-sectional or prevalence studies. And in analytical studies, you have case control and cohort studies. So first, the case report. So basically, a case report is the profile of a single patient, and it's reported in detail by one or more clinicians. So these are usually things that are developed by clinicians and are really important for study design, for developing hypotheses about patients. So some examples in the literature of case reports. So this is one case where you have a patient with a 4-day incubation period of some bacteria infection in a non-immune patient in Ghana. So this was a case report that happened here in Ghana and was published internationally. Another case report looks at the effects of chemotherapy on cancer that invades the bladder, and it looks at 3 cases. And there's another case report of looking at the case of the season, where on Saturday night someone gets an attack of palsy. In a case series, it's multiple case studies. So in a case reports. So an individual case report that has been expanded to include a number of patients of a given disease, but usually this is a small number of patients. So there's an example taken out of Brazil, looking at ultrasound imaging for identification of cerebral damage in people with Zika virus syndrome, when pregnant women get the Zika virus. But they didn't have enough large sample, so they did a detailed analysis looking at case series. Then the cross-sectional studies, which is another type of descriptive study, where you're looking at information collected at the same time point or in a period time point. And what we try to do with cross-sectional studies is take a snapshot of the health state. So these are designed to obtain information from samples regarding prevalence, distributions, and interrelations as well. And this is really important, especially where you have an epidemic, for example. So we could think of Ebola, where you have a sudden outbreak of, especially when people didn't know what Ebola was, doing a cross-sectional study would have been really important, and they had done that in order to be able to intervene quickly. So you take a population and you see how many people have this, what is the location of people who have this disease, and you can look at distributions of patients to avoid certain areas as well. So another example is the survey. So in a survey, you take a survey in a given period of time. There are no typical formats, and they're designed or modified to meet the needs of the researcher and fit the topic of research. And in a cross-sectional study, typically what you have is some source population. You have a group that's eligible, meets the criteria, a group that's not eligible, and there could be different inclusion and exclusion criteria. Among the eligible population, you have people who participate and people who don't participate. And what you want to do is get a measure of who is exposed to a certain condition and has a bad outcome. So it could be who's, in the example of Jon Snow, it could be, or the cholera outbreak, it could be who's exposed to a certain pipe and develops cholera, who's exposed and has a good outcome, so who's exposed to how many people are exposed to that particular pipe and didn't develop cholera, or unexposed and have a bad outcome, so people who didn't use that particular pipe but still got cholera, and people who are unexposed and had a good outcome, so they had no exposure and they were fine, so they're like a control group. So now I'll go on to talk about the analytical studies, so the case control study and the cohort study. So these come under the umbrella of what's known as observational studies, and observational studies are very powerful. So the main objective of an observational study is to test the hypothesis of the relationship between exposure to risk factor and disease or other health outcome. And you could look at, one of the reasons observational studies are so good is because they're very cheap to look at as well. So it's very cheap to collect data quickly and look at this. So we look at measures of association. So is a particular outcome associated with a particular disease? So we can think of the example of if you have a child that doesn't play, just sits in and watches computer games, are they more likely to develop asthma? And this is something that has been studied and that you can use in an observational study, because you're not going to experiment on children and say, okay, you have one group who's going to sit all the time and one group that's going to play. It's unethical. So there's some cases where doing a randomized control trial isn't ethical, so you just have to observe what are the phenomena in the population. And so the magnitude, precision, and statistical significance of an association is determined. So how strong is that association? And the sort of gold standard of observational studies are cohort studies. And in a cohort study, you identify a group of subjects. It could be people in this room, for example, and we follow them up over time. So if we follow up the people in this room over 5 years, and we compare event rates, subjects exposed to risk factors and those not exposed to risk factors. So we could think those who travels more than 3 hours and those who didn't travel more than 3 hours, and then we follow up over time. So cohort studies could be retrospective. So that's where you have a population and you look at things, events that happened in the past, and you ask people to recall things and you ask them questions. Or they could be prospective. So if we took the population in this room and we followed us up in 7 years, 10 years from now, and looked at different risk factors. So in a cohort study, you have your source population, people who are ineligible, and eligible. In the eligible, you measure those who are exposed or not exposed, and you look at who has bad or good outcomes in both the exposed and unexposed, and you try to see whether there's some sort of effect. So I'm just going to touch a bit on randomization and good criteria for randomization in the context of randomized control trials, which I talked about before. So randomization is a really important concept for setting up studies and good study design as well, where we have an experiment. So if we want to give an intervention, for example, if we have the population in this room and we want to randomize people, give some people vitamin D, and just tell other people, look, you have sunlight, let's see whether our vitamin D levels go up with no intervention. So the definition is the process by which allocation of subjects to treatment groups is done by chance without the ability to predict who is in what group. So if you do randomization well, I can't predict who I'm giving medication to and who I'm not giving medication to. It's random allocation. So we're not introducing any sort of bias in our analysis with some factor that can be measured. So the aim of randomization is to prevent statistical bias in allocating subjects to treatments, and also to achieve comparability between groups and to ensure that samples are representative of the general population. So an example in this room, if I randomize people to receive vitamin D and receive sunlight, I'd want balance in gender as well. So you'd want equal numbers of male and female in both groups. And the way to do that is by random allocation. So if I select people randomly, it should be representative of the population in this room. And there are different methods for doing randomization. So one is simple random sampling, where you just, you have a population and you just assign numbers. So if I went through this room and just said 1, 2, 3, 4, all the people with numbers divisible by 3 in one group and everybody else in another group. And we divide our samples like that. Another more complicated way of randomization is permuted block randomization, where rather than giving people numbers and then randomly selecting numbers from a hat, we say, okay, you're 1, 1, 2, 2, 1, 1, 1, 2, 2, and you put people in different groups like that, or you can have stratified random sampling as well. So that's where you have a population, and we have different strata in the population. So I think the most obvious strata would be male and female. And then we sample from those groups so that we have equal numbers for the different groups. So any questions up to now? Okay, no questions. So I'm going to go on to my top 10 data science skills for building good predictive analytics for healthcare. So number one is receiver operative characteristic curves. So these are really important techniques, and they're useful tools for diagnostic test evaluation. So when we have healthcare data, what we're trying to do is make a prediction. So what we observe is that there are people who have no disease and people who have a disease, and then we want to maybe predict. Can we predict whether this person with a given exposure has no disease or has the disease? So if the person, so basically with receiving operative characteristic curves, we're trying to see how well does a certain test give us the right answer. So, for example, the test could be people who are vegetarian. So I don't think many people are vegetarian here, but imagine there was, so I say this because I have a friend from Ghana who says vegetarianism does not exist in Ghana. I don't know, maybe they are, but imagine there are vegetarians, and maybe it does, in which case, please correct me. So imagine we wanted to see whether being vegetarian makes you more likely to get colds, to get the virus, and become ill. So imagine that was our marker. So if we use that as our marker and we found that all the people who are not vegetarian have no disease, and our prediction is right, then we call that the specificity. So we say that our test is specific. But if we get it wrong, so imagine that they have the disease, but our diagnostic, which is this person is not vegetarian, but they still have the virus, we call this a false positive because the test we're using is false. And this is what's known as a type 1 error, or alpha. So typically in statistics, you talk about this as your level of significance. So that you can say that vegetarianism, not being vegetarian, I keep mixing them around, not being vegetarian predicts disease with a 5% level of significance. And that 5% is what is the probability of making this error. And then we have the power of the test, which is what is the probability that the person has the disease and also our marker is right. So they're vegetarian and they have the disease. This gives us the sensitivity of the test, and that's the statistical power. And if we get it wrong among people who have that marker of being vegetarian and they don't have the virus, we call that our false negative, or the type 2 error. So I'll give an example of using a ROC curve with some work that I've done previously looking at peanut allergy, where peanut allergy is something that's prevalent in Europe, but it's very hard to detect quite quickly. So the only way to detect peanut allergy is by giving someone, with 100% accuracy, is by giving someone peanuts. And if you give someone who's peanut allergic peanuts, you could kill them. So it's not a very good test to run on someone. So we were looking at this marker called RH2. And we wanted to see, does RH2 help us to distinguish between people who are allergic to peanuts and not allergic to peanuts? So we have two distributions. We have a distribution of patients with peanut allergy and another distribution of patients without peanut allergy. And this is their IgE response. And the IgE is the level in your blood of this particular component called RH2. And then we have another distribution of people with peanut allergy. And we see that the distribution, the mean value is higher in terms of IgE response. And so we defined a threshold for RH2, which is an IgE of 3.15. So if you're less than that, you're likely to not be peanut allergic. And if you are greater than that, you're likely to be peanut allergic. And this is where we have those concepts I showed on the first slide. So you have the true positives would be those who are above that threshold and are peanut allergic. The false positives would be those who are above that threshold but are not peanut allergic. The true negatives would be those who are diagnosed correctly. So they have an IgE less than 3.15 and they're not peanut allergic. And we have the false negatives. So people who are peanut allergic but they lie outside of that. And then we can draw a ROC curve. When we set, so the ROC curve, what we do is we set different thresholds based on this measure of RH2. So we look at, if we use that as a threshold for detecting between people who are peanut allergic and not peanut allergic, with 100% accuracy, we have a true positive rate. So everyone on this side isn't peanut allergic, but there are some people on this side who are peanut allergic, who are not peanut allergic as well. So that's the false positive. And we could draw different lines on this graph. And we could plot each of those lines to see what are our percentage of true positives and false positives. And then we draw a ROC curve. So these are simple ways to see whether a particular diagnostic or a particular marker is distinguishing between patients. Skill number 2. I have 20 minutes to talk about my skills. So there's, right. So the second skill is that of statistical power and sample size calculation. And this is really important to see whether the number of people in a study is sufficient for detecting some difference at a level we set it. So this is a really important calculation, and there are ways to automate these calculations, power calculations, to see whether our study is sufficient. So we have a sample size, which is n, and we have some ratio of cases to controls, or controls to cases, which is this r here. And we have a measure of the standard deviation of the outcome variable, and we have a measure of the statistical power and the statistical significance over the effect size. So these are calculations that we'd want to do to see whether a study is statistically powered. And this is a very important concept. So that's my second skill. The third skill is that of data visualization. So there's a really good website, towardsdatascience.com. And there's a blog, 5 quick and easy data visualizations in Python with code. It's a really good blog. But in this particular blog, the person who wrote it has different measures of how to visualize data in different scenarios. So visualizing data gives us a good bird's eye view of what does the data tell us. And we can see quick insights into the data without even doing analysis. So really this would be step 0. Once we have data, can we do some meaningful visualizations, some sort of box plots, bar charts, just to see the distribution of the data. The fourth skill is A/B testing. So for the statisticians among us, this is your t-test, your Mann-Whitley test. And it's basically where you have a patient group. You split the patient group into 2 populations, random, so we do randomization on those populations. We give one group an intervention, we give one group a control, and we want to see the outcomes for both groups. So in one group with the intervention, we see a higher proportion of people who are cured. In the second group, we see a lower proportion of people who are cured. So it seems that the intervention is better than the control. And this is another important skill for data science, predictive healthcare statistics, and maybe one that we take for granted, where if you just change one variable in a patient, what differences do you see in 2 populations? Fifth skill, linear regression. So linear regression allows us to look at linear relationships between one normally distributed interval predictor and a normally distributed outcome. So your predictor could also be binary as well, a yes-no variable, and you want to see differences on a continuous variable. So an example that I've worked on before is looking at the relationship between forced expiratory volume, so that's a measure of your lung capacity, and whether that's related to IgE. So IgE is this measure of allergy I showed before at age 5. So in other words, we want to predict FEV from IgE. So we want to predict lung function, how asthmatic someone is, from their allergy response. So if we run a linear regression model in our favorite statistics package, so this is a really simple linear regression using SPSS. So we have an outcome, which is the IgE, and the thing we want, we have a predictor, which is IgE, and the thing we want to predict is lung function. So we see that the relationship between FEV and IgE is negative. So the higher your IgE, the poorer your lung function. So as IgE goes up, your lung function goes down. And based on the p-value, which is here, this column called significance, it's less than 0.05. So we have a p-value of 0.027, and we conclude that the relationship between IgE and FEV is statistically significant. Skill number 6, logistic regression, things we take for granted. So with logistic regression, what we want to measure are what are the odds. So in this example, I have asthma between 0 and 8 years, and whether or not you've been given antibiotics in the first 12 months. And we can do calculations to see what's the odds of developing asthma if you took antibiotics, what's the odds of developing asthma if you didn't take antibiotics. And so here we see that if you took antibiotics, your odds of developing asthma, if you do the calculation, is 1.48. So you're 48% more likely to develop asthma if you took antibiotics, whereas if you don't take antibiotics, you're protected from asthma in this particular study. And then we could calculate what's known as the odds ratio. So the odds ratio is the odds of taking antibiotics over not taking antibiotics, which is 2.49. So compared to children who don't take antibiotics, if you take antibiotics, you're 2.49 times more likely to develop asthma. And using logistic regression, this is essentially what we calculate those odds. Skill number 7, causal reasoning. So the question that motivates most studies in healthcare is causality. And okay, we can look at associations, but really what we want is to identify what are the causes. So before an association is assessed for the possibility of a causal other explanations such as chance, bias, and confounding, they have to be excluded. And to establish causality requires some knowledge of the data generation process. So it can't be computed from the data alone. We have to understand the distributions governing the data and how things are related as well. So the aim of causal reasoning is to infer dynamics of belief under changing conditions, for example, changes induced by treatments or some external intervention. And there's a paper by Judea Pearl, who's one of the fathers of causality, on causal inference in statistics, where he gives an overview of causality in statistics. And in order to establish causality, Bradford Hill were the first people who observed the association and said that this association is causal when they looked at the association between lung cancer and smoking. So back in the 70s, I see the statistician smiling. So back in the 70s, this was they wanted to know, okay, there was a lot of debate, does smoking cause lung cancer? So now we know smoking causes lung cancer, but 50 years ago, this was not so obvious. And after they did a study to identify this, they asked, well, what are the principles for saying that something is causal? So the first principle is that it's plausible. So does causation make sense? Consistency, that the two things are always associated, and if you look at different populations, you see that effect. So in different populations, anywhere in the world you go, you see that there is a strong association between smoking and lung cancer. temporality, so that you don't have cancer and then smoke, but that you smoke and then have cancer, so the cause comes before the effect. The strength of the association, that it's strongly associated. Specificity is a bit of a weaker principle of causality, and that just says, is it just one cause? So are there other confounding causes with smoking? It's just one cause, but this is a bit weak. And dose response. So the greater the exposure, the more you smoke, the greater the risk, the more likely you are to get lung cancer. So smoking causes lung cancer. And another example of looking at causality is looking at the effect of treatments on an outcome, on survival. So in this example, we have a treatment which is given to people with some cancer, so they have a tumor size as a variable, and we think that treatment affects tumor size, and this affects in turn your survival. So treatment would have some direct causal effect on survival, but also there's an indirect effect. And then there are other factors which are moderators. So depending on your genetic makeup, this can affect the tumor size, but also it can affect the effect of treatment on your tumor size. And there may be other risk factors as well. So with these sorts of examples, what we try to do is tease out causality and tease out the causal modeling framework. And there may be other things that are unmeasured confounders as well that we want to take into account. So this would be like the error terms in the model. Right. Skill number 8, which I mentioned at the beginning, very important, is missing data. So when you have a data set, one of the first things you should do is look at the distribution of data, look at responders and non-responders. And this is especially relevant in health data. It's also relevant in economic data as well. Is there some mechanism for why people are missing data? So there are 3 broad assumptions to missing data. The first assumption is that the missing data is missing completely at random. So this means that the probability of data being missing doesn't depend on anything you've observed in the data set. The second assumption about missing data is that your data is missing at random. So this means that the probability of data being missing depends on something that you observe. So you could model this. And this would be an example of, so the first, missing completely at random. It could be, imagine you have some samples and the samples get lost in the post. That's random if it gets lost. The second example, missing at random. So imagine you're doing a study on children with lung function, and you find that children with missing Wheeze data have better lung function. So they are not incentivized to be in the study, but you can predict what their lung function is because you have you could predict what their Wheeze is because you have their lung function. So you observe something in the data. Missing not at random is where the probability of data being missing does depend on something that's unobserved, and this is a lot harder to test. So, for example, if you have children with missing lung function data have better lung function. So if we do analysis on the distribution of children with lung function data, but then there's a part of the distribution missing, so people with better lung function are missing, then it means our whole distribution and all the assumptions we make about that population are heavily skewed. Right, we're getting to the end. Skill number 9, latent variable modeling using probabilistic programming. So the purpose of latent variable modeling is to identify subgroups of complex disease risk. And this is something that's very human. So this is, I don't know, this illustration was supposed to be, I think it's called something like out of chaos order. And this is something that's very human. We look at patterns and we try to identify patterns in things that are random. For example, if you go to a doctor and you say, oh, I've noticed this, that, and the other happening, the doctors do the same thing as well. They look at different patients and they say, oh, this is a common trend among patients, and it helps to pick things up. And the purpose of looking at these, seeing whether we can identify strata in disease, is to get better targeted interventions. And typically with latent variable modeling, what you do is you have some features or some things you observe. So these could be different symptoms that you observe. And we want to infer some parsimonious description of the data from what is observed. So these would be latent variables, or what are called endotypes, which are based on our observations, which are phenotypes. So one of the examples I've worked a lot on is that of asthma. So asthma is, we came up with the hypothesis that asthma is actually an umbrella term covering multiple diseases. So looking at longitudinal data collected over time for children, we looked at different things. We saw that there are different observable manifestations of asthma, like if someone is hospitalized for asthma, they have poor lung function, they wheeze, they have allergy, they have symptoms. Very often, if you go to the doctor, you get a single diagnosis of asthma. But what you notice is that people don't respond in the same way to treatments. And also what you see is that some people grow out of asthma, some respond to treatments, some don't. Some develop asthma later on in life, and there are different levels of severity. So these could actually be different diseases. So using these sorts of techniques, we're able to disaggregate what is this umbrella term asthma and identify these different types of asthma. So using probabilistic programming techniques, we can use these sorts of models. So we have a probabilistic model of how we think the world actually is. We run an inference algorithm using our data and asking different queries in order to get an answer. Last skill is interdisciplinary research. So an important aspect of doing predictive analytics for health is that it's not done the data scientists in a room with the data by themselves. And I think this is something one of the earlier speakers brought out quite clearly, that discoveries about healthcare need to come about in a collaborative effort with data scientists, machine learning researchers, computer scientists, and different experts in the room, and also with people with domain knowledge as well. And context really matters in healthcare research. So we need to really think deeply about the clinical context in order to find solutions to those problems. And doing healthcare predictive analytics is about looking at the bigger picture as well and seeing how everything fits there. So I just want to take you back to the first few slides, which is the take-home message, that at the heart of all we do, predictive analytics for healthcare needs to be patient-centric research. And anything we're looking at, when we're looking at any data, we have to have this very much in mind. And this has a lot of implications, and these are implications I haven't talked about in this talk. So things like fairness, and things like how do we make sure that people get equal intervention. So as was mentioned in the introduction, I work in Microsoft Research in Cambridge, and these are the people that I work with and collaborate with. Aditi Nori, who's the head of the team, and it's a fantastic team. And thank you for listening and not falling asleep. And for the crack about Jon Snow as well, that's very funny. I'm going to use that next time. And I'm happy to take questions. I think I have a couple of minutes for questions.